group of pharmaceuticals which, although generally does not prolong survival, but still, if used prudently and according to the results of large trials, will help cardiac patients immensely. And we will divide the lecture into several subgroups. We will start with the slide does not advance.
حضرتك غير حضرتك السلايد من السهم.
من السهم. We'll start with the basic concepts of the cardiac action potential. The cardiac action potential needs some explanation, but this is a summary of the different phases, the 5 phases of the cardiac action potential. الصوت واضح؟
صوت حضرتك واضح.
Phase 0 is a sodium current which enters in the myocardial cells, and then this is followed by phase 1, which is a transient potassium outward current, and then after that the plateau, which depicts a balance between inward calcium current and outward potassium current. There are 3 potassium currents that are known to contribute to this area. The slow component of the delayed rectifier calcium current, and I will explain what does this mean, and the rapid component of the delayed rectifier potassium current, as well as the ultra-rapid component of the delayed rectifier calcium current. Let me explain what is meant by delayed and the rectifier. Delayed means delayed in the action potential, because as you get delayed in the action potential, the calcium current trails off and the potassium current becomes more prominent. And the rectifier current, this means that it depends on the membrane potential. The relation between voltage and the current, is usually ohmic, means linear. But in the cardiac channels and in the nervous channels, in the muscle channels, it's curvilinear. It's not a linear relationship between voltage and current. At one point, there is no flow of the ions completely. This point is called the reversal potential. If you are positive to the reversal potential, the potassium current moves outward. If you are negative to the reversal potential, the potassium current moves inward. This process is called the taqweem or rectification. If this process occurs slowly, it's IKS. I means the current, K potassium, slow component S. If it's rapid, it's IKR. If it's ultra rapid, it's IKUR. And this means this last potassium current exists only in the atrium. It's not existing in the ventricle, it's not existing in the Purkinje fibers. And as a result of that, vernaculant acts on this current, and therefore it does not have a pro-arrhythmic effect. This is the reason the ECS guidelines removed the phytolide and put vernaculant in the treatment of atrial fibrillation with normal hearts. I will come to that. As we move from phase 2 to phase 3, the potassium currents that we just explained now are getting dominance, and the calcium current, which is going inward in phase 2, trails off. And then the last potassium current, which clamps the repolarization process, is the IK1 current. This IK1 current is characteristic of non-pacemaker cells. In the pacemaker cells, it is lacking, and therefore, in addition to 2 other currents, I calcium T, the T type of calcium channels, as well as the IF current. IF current means the current which is funny because it's activated in this area. I hope you see the arrow. In this area, which is hyperpolarization. So that's why it's called the IF current. So IF current, in addition to the T type of calcium channel current, in addition to lack of IK1, is responsible for the diastolic depolarization. If you don't have these currents, then there is no diastolic depolarization, and by the end of phase 3, you get a normal electric stability at the baseline. Now, if you look to this diagram, you will realize that the action potential is extremely heterogeneous in the myocardium. And this is the reason the myocardium is very vulnerable to arrhythmia. If you go from the sinus node, you will find that the action potential is completely different from the action potential that we just explained in the ventricle. The zero phase or phase zero is slowly rising and is calcium dependent. And the duration of the action potential is short. If you move from the sinus node to the atrium, it's because of the presence of the IKUR that we just explained. It's short the duration of the action potential. And this is because it's a working myocardium, there is no diastolic depolarization. Now, if we move into the AV node lacks the intercalated discs, and therefore conduction is slow, and there is diastolic depolarization because it contains pacemaking cells. Now, if you move now into the ventricles, you get the full-blown picture of the monophasic action potential with its 5 phases that we just explained. In the middle layer or the M band of the myocardial wall, this action potential duration is wider than both the epicardium and the endocardium. Now, and in addition to that, if you summate the various electrical activity in the atrium, this is inscribed as a P wave in the electrocardiogram. If you submit the different monophasic action potential in the ventricle during phase zero, this produces the QRS complex. And then during repolarization, it depicts the QT interval. So this is the basic simple physiology which explains what we are going to talk about. The von Willebrand classification was proposed in the late 70s, early 80s, and it is still stood the test of time, though it is simple and lacks everything and contain every details about the antiarrhythmic drugs, but it classifies the antiarrhythmic drugs into 4 components. Sodium channel blockers, which inhibit phase zero, and as a result of that, it slows conduction in ventricular and atrial myocardium. Beta blockers, which has its major effect on the sinus and the AV node, and has additional effects on the autonomic nervous system. Class 3, which is potassium channel blockers. All the drugs, when they block IKR. There is very rare drug which is now obsolete called the mibafrandil. We used it in the past, which was the only I calcium T current blocker. All the others are blocking IKR and not IKS. So as a result of blocking the potassium channel, it prolongs phase 3, which is the repolarization and the QT interval. And the class 3, which is the calcium channel blocker, which has its major effect on the AV node and to a less extent on the sinus node. There are other drugs which are not included in the von Willebrand classification, including adenosine, digoxin, atropine, and magnesium. And we will come to that. Now, this is another classification of the antiarrhythmic drugs, which was proposed in the early 90s, called the Sicilian gambit. It shows the effect of the various antiarrhythmic drugs on the various channels, receptors, pumps, clinical effects, and ECG. It's too complicated, although it's very scientific and includes a lot of information. I just brought it here for your reference, but you are not supposed to be much engaged with the application of this. Now, this is the diagram which led Hodgkin and Huxley 50 years ago to win the Nobel Prize for Physiology. So we have the sodium channel here present in 3 forms: a resting state, an activated state, and an inactivated state. The sodium channel has 2 gates, an M gate. These are amino acids, an M gate and a chain, and a ball gate called the H gate. And what happens is that during the depolarization, the membrane, the cell membrane of the myocyte gets depolarized. If it reaches -40, this is the threshold at which the M gate opens. Now, this moves the cardiac sodium channel from the resting state to the activated state. And as a result of that, sodium rushes in, and the complete depolarization for phase 0 develops. Now, this lasts only 1 to 2 milliseconds. So it's voltage dependent and time dependent. Following that, repolarization starts, and this is ushered in by the blockage of the sodium channel by the chain and ball H gate. And as a result of that, repolarization will occur. Calcium and potassium will do whatever we explained just now until we get into phase 4. And as a result of following that, we will get conformational changes in the sodium channel, which will let it go back to the resting state again to be activated. Now you will find that in group A, in group 1A, most of the action is related to attachment of the antiarrhythmic drugs to the activated state of the sodium channel. And in group 1B, it's attached to the inactivated sodium channel. Now this is clearly here. If we are going to detail class 1, it includes class 1A, quinidine, procainamide, or disopyramide. They have intermediate kinetics. What does this mean? These drugs attach to the channel, which is the receptor of the drug. They attach and then they detach. If they attach slowly and detach slowly, this means it's slow kinetics. So this means that it cannot be detached easily. So it's a very strong drug, and this constitutes group 1C drug, flecainide and propafenone, and previously morphine, which is not available now. If you have a rapid attachment and detachment, this is rapid kinetics, and this is a feature of group 1B, including lidocaine and mixilidine. Intermediate is quinidine, procainamide, and disopyramide. But in addition to its intermediate kinetics, these 3 drugs of group 1A, they have also a class 3 effect, so they prolong the action potential duration, and they can cause torsade de Pointes. This is an important point, because this is the only subgroup of class 1 antiarrhythmic drugs which has the class 3 effects and prolong the cure. This means that if you use this drug, which most of them are not used now except disopyramide and which is rarely used, you have to watch the QRS width and the QT interval, because it has a sodium blocking effect as well as a potassium blocking effect. Now, lidocaine and the mixilidine, they have rapid kinetics. Now we understand what is meant by rapid kinetics. They have very little effect on the atrial tissue, and they are very specific in the ischemic myocardium. That's why we use lidocaine, or we were using lidocaine immensely in the initial stages of myocardial infarction, and to a less extent we were using the mixilidine. And we will detail that later in this lecture. The most important group among the class 1 antiarrhythmic drugs is 1C, which contains the flecainide and the propafenone. They have slow kinetics, which means that the detachment from the channel is impaired or slow, so they are very powerful drugs. They are the most important sodium blocking agents we have. Unfortunately, they have a negative inotropic effect. Now, if we move to class 2 beta-adrenergic block, these are the beta-adrenergic blocks among others. The mechanism of action is blockade of the beta-1 receptors. If you look into this diagram, activation of the beta-1 receptor will activate the stimulating component of the G protein, activate adenine cyclase, and this will change cyclic ATP into cyclic AMP, which phosphorylates the calcium channel and opens it. So the downstream effect of calcium antagonists is equivalent to the downstream effect of beta blocker. That's why you should be very cautious in combining them, because the final pathway of their action is the same. Now, their effect is essentially in slowing the sinus node, prolonging AV nodal conduction, inhibiting automaticity, and blocking the sympathetic innervation and the effect of circulating catecholamines. Now, if we move to class 3 potassium channel blockers, it contains sotalol, dopitolide, and ibutolide, and amiodarone. Amiodarone is unique in having the effect of the 4 classes, class 1, 2, 3, and 4. Dronidarone lacks the iodine ion of amiodarone, but it has, again, the same 4-class effect like amiodarone. The mechanism of action is blockage of the potassium current, essentially IKR, not IKS. Very rarely you get the blockage of the IKS by any drug available on the market now. And as a result of blocking the IKS, which is the slow component of the rapid rectifier potassium current, you get prolongation of the action potential duration, prolongation of refractoriness, and torsade pumps in the majority of these drugs. An exception is amiodarone, which produces torsade pumps in less than 1% of individuals. Now, moving to the last group, the calcium channel blockers, we are excluding the dihydropyridines. We are talking about the non-dihydropyridines, verapamil and diltiazem. The dihydropyridines, they have no effect on the conducting channels. Their effect is blockade of the L-type calcium channel. They decrease the cytosolic calcium, and as a result of that, they prolong the AV nodal conduction and refractoriness. They produce mild sinus slowing effect and mild reduction in automaticity. Now, in the late 80s, the thought was like this. People thought if people are dying generally from ventricular fibrillation and ventricular tachycardia, particularly pulseless ventricular tachycardia, and if both of these conditions, pulseless ventricular tachycardia and ventricular fibrillation, are ushered in by frequent PVCs or non-sustained ventricular tachycardia, why don't we use the most potent drugs available at that time, which was incanide, flecainide, and noricicine, to block the PVCs and the non-sustained ventricular tachycardia, and thereby block the occurrence of ventricular tachycardia and ventricular fibrillation. So the theory was appealing to everybody. The National Institute of Health conducted this trial, and we got a big surprise, which made the CAST trial a landmark trial in the history of cardiology, and opened the window for the randomized trials. So not everything which looks physiological is true by randomized trial. So what happened? What happened is that these drugs, they were applied in a running phase, in which they successfully suppressed the PVCs and the non-sustained ventricular tachycardia. But instead of saving the patients from mortality, mortality was actually doubled by the use of these drugs. So this was a big discovery at that time, by indicating that patients should not take any of these drugs. As a result of that, the whole group of class 1 indication had a black label by the FDA not to be used in patients with ischemic myocardium. And since then, we learned the lesson of proarrhythmia as a result of the CAST trial. So the CAST 1C should not be used, and better, all class 1 drugs should not be used in a diseased myocardium, particularly the ischemic myocardium. Following that, we have studied a SWORD study which tested disotalol, also increased mortality. The Diamond study which tested dofetilide, the results was neutral. The ALIVE trial which tested azimilide, the results was neutral. The Andromeda trial which tested dronidarone, mortality was increased, and then we get at least 5 trials for amiodarone, and we got mixed results. Until we get into the SCAD-HEFT trial, which put to rest the use of amiodarone to prevent ventricular tachycardia and ventricular fibrillation and cardiac arrest. You saw the last time this curve. It's a trial essentially which was matching the ICD against a placebo or amiodarone. And the ICD decreased the mortality rate by 30%, and there was no statistical difference between using a placebo or amiodarone. And I said last time, at least amiodarone did not kill people. But we will learn from this study that cardiac arrest, ventricular tachycardia, and ventricular fibrillation could not be prevented by amiodarone. There is no one antiarrhythmic drug which improves survival, unfortunately. Now, we will now move to the treatment of various arrhythmias, starting from the most lethal to the least serious. So this is taken from the ACLS guidelines for the treatment of ventricular tachycardia and ventricular fibrillation, which results in cardiac arrest. So usually these patients, they got shock in addition to pumping the chest. So if there is failure of shock and the epinephrine treatment, then the drug of choice or the next choice will be amiodarone in this dose. Unfortunately, in Egypt, we don't use the intraosseous route. I think all the residents should be trained in using the intraosseous route. They can be taught that by the anesthesiologist. This is an injection through the upper end of the humerus or the upper end of the tibia. There is a special device for that, but the anesthesiologists locally here usually use a thick needle for that. If you get an intravenous line, that's good. If you come to get an intravenous line, we use the transbronchial. This is now obsolete, and the intraosseous is the substitute for that. Amiodarone is definitely much better than lidocaine in treatment of ventricular tachycardia and ventricular fibrillation, but lidocaine should be considered as an alternative if amiodarone is not available. The guidelines of 2005 and 2015 removed the procainamide and the bretillium from the ACLS algorithm for simplicity. Now, this recommendation is based on these two studies: the ARREST trial, which tested amiodarone against a placebo, and definitely amiodarone improved the survival in patients admitted to the hospital after having an out-of-hospital VT or VF arrest. And the other trial was a live trial, which tested amiodarone against the lidocaine, and the winner was amiodarone. And based on these two studies, the recommendations which is applicable so far is using amiodarone in the dose I indicated. Remember, the dose was 300 milligrams intravenously or intraos. This is different from the use of amiodarone in the treatment of sustained monomorphic ventricular tachycardia, which is the dose is half of that, 150 milligrams intravenously to be injected over 10 minutes. You can repeat or use the dose which is known to everyone. And second choice is procainamide, although it's more efficient than amiodarone in treating monomorphic ventricular tachycardia, but since it's not available and the oral form is now obsolete, then amiodarone is still at the top of the list in treating the monomorphic ventricular tachycardia. Lidocaine can be used, but it's less effective. In idiopathic ventricular tachycardia, like right ventricular outflow tract ventricular tachycardia, left ventricular outflow tract ventricular tachycardia, or fascicular ventricular tachycardia, Bilhassen disease, we use beta blockers, verapamil, in the treatment of these conditions. Now, antiarrhythmic drugs are usually used successfully in preventing shocks in patients who are having an ICD implantation. And this is based on two studies. One study was comparing sotalol to a placebo, and definitely sotalol was more successful than a placebo in preventing the ICD shocks. And the more important trial is the OPTIC trial, which compared the beta blockers against sotalol against the combination of amiodarone and beta blocker, and the winner was amiodarone again. So we have for the prevention of ICD shocks, we have amiodarone better than sotalol, better than beta blocker. But usually we use sotalol for this particular specific indication because it's more safe and less toxic than amiodarone. But if it fails or if it's not available, amiodarone. Now, the treatment for the less serious arrhythmia, like supraventricular tachycardia, as we indicated before, we use vagal maneuvers. The vagal maneuvers fail, we give intravenous adenosine as a bolus rapid injection. If then the patient is hemodynamically stable and adenosine is not effective, which is rarely the situation, we can use beta blockers or intravenous diltiazem and verapamil. An important caveat here is that verapamil and diltiazem is as effective as adenosine. Adenosine should be given very rapidly because it's metabolized by the red cells. So in order to reach the heart, it should be given as a bolus, very quick injection. In contrast to the injection of verapamil, which should be given very slowly to avoid hypotension, and consequent sympathetic stimulation, which accelerates the supraventricular tachycardia. If the patient is hemodynamically unstable, or if these drugs fail, then we can use synchronized cardioversion. Now, this is a very famous slide for the antiarrhythmic drugs which are used to maintain sinus rhythm in patients with atrial fibrillation. This is the latest guidelines. It divides patients with atrial fibrillation, which has been cardioverted into sinus rhythm, into 4 categories: no structural heart disease, substantial left ventricular hypertrophy. Defined in these guidelines, it was 1.3, changed it to 1.5, coronary heart disease and heart failure. And as you see here from the dotted arrows here, that catheter ablation can be the first choice in all of them. But this is not the usual practice. The usual practice is that if you have no structural heart disease, you can use all of these. These are arranged alphabetically, not in the order of preference. If they fail, you can use amiodarone or catheter ablation. If you have left ventricular hypertrophy, you can start with dronedarone. If it fails, amiodarone or catheter ablation. For coronary artery disease, you can use dofetilide, dronedarone, and sotalol. If they fail, amiodarone or catheter ablation. For heart failure, the choice is limited to amiodarone and dofetilide. This is the American guidelines. It differs from the more recent European guidelines, which remove the dofetilide completely because of the restriction. You have to give the patient dofetilide after hospitalization for 3 days. This is the international recommendation to avoid the 1 to 5% occurrence of torsade dopants. So the dofetilide in the European guideline has been removed and has been replaced by vernaculant, which, as I said before, it blocks the IKUR, the ultra-rapid delayed rectifier potassium current, which is specific for the atrium. Dofetilide produces proarrhythmia because it acts on the ventricular channels. Vernaculant does not produce ventricular arrhythmia, so it's not proarrhythmic because it acts only on a channel present in the atrium alone. Now, this recommendation is based essentially on these 3 trials: the Canadian trial for atrial fibrillation, the safety trial, and the Dionysus trial. And these trials showed that amiodarone is better than antiarrhythmic drugs, including sotalol and propafenone. And on the average, amiodarone maintains the sinus rhythm for 1 or 2 years in 60% of individuals, whereas the other antiarrhythmic drugs, including sotalol, propafenone, dronedarone, maintain sinus rhythm for 1 to 2 years in 40%. There is a difference about 20% in favor of amiodarone. 10 years ago, we got dronedarone, which is equivalent to amiodarone, except that there is no ion here. And this saved the patients from 2 things. Number 1, from loading condition, because actually the volume of distribution is much smaller, and the patient gets the steady state after 1.5 days or so, because the elimination half time is just 30 hours. This is in contrast to a huge 50-liter volume of distribution for amiodarone and the need of giving 8 to 10 grams as a loading dose of amiodarone before you maintain the patient on the dose. The second thing is the less toxicity because of the removal of the iodine ion. So it's an amiodarone analog without iodine. This is the dose. The half-life is much shorter. It has a similar mechanism of action. And as we said, amiodarone possesses the action of the 4 classes of the von Willebrand classification, and the same applies to dronedarone. An important point to observe is that this drug is used only for the maintenance of sinus rhythm in patients with atrial fibrillation. So if the patient is not in sinus rhythm, you cannot give it. And after 3 or 4 weeks, if the patient returns to atrial fibrillation, then you stop it. And I will come to this again. There is no place for dronedarone in the treatment of ventricular arrhythmias. These trials that led to the approval of dronedarone includes these 2 studies combined, and this showed that dronedarone in patients without structural heart diseases, it improves the maintenance of sinus rhythm compared to a placebo by a margin of about 20%. And in the Athena group, which is a pivotal trial which led to the FDA approved, includes 4,600 patients with atrial fibrillation. The death and mortality, as well as cardiovascular hospitalization, was less with dronedarone than with placebo effect. So it was approved because of its safety rather than because of its efficacy. Now, there are two studies which tested against its safety: the Andromeda trial and the Pallas trial. In the Andromeda trial, dronedarone was tested in patients with class 2 to 4, class 2, 3, and 4 heart failure, ejection fraction equal or less than 35, and it turned out that it increases the mortality in these patients and increased the congestive heart failure hospitalization. So as a result of that, the use of dronedarone is banned in patients with moderate to severe congestive heart failure and left ventricular dysfunction. And the Pallas trial revealed that patients with permanent atrial fibrillation, they get more stroke, myocardial infarction, death, and embolism and death. So again, it's not indicated in patients with permanent atrial fibrillation. So dronedarone have a lot of caveats in its use, although it's highly efficient as a drug to maintain sinus rhythm in patients with atrial fibrillation. Now, realizing that, we go to the first questions. You are going to initiate dronedarone for the treatment of symptomatic atrial fibrillation in an old man that you are seeing in your office. His other medications include warfarin, omeprazole, digoxin, pravastatin, and desulfonylurea glyburide. Which of the following should you use at this time? Decrease the dose of digoxin, arrange for serial measurements of serum creatinine, reduce warfarin dose and arrange for more frequent INR checks, change pravastatin to simvastatin, or reduce the dose of the sulfonylurea. The correct answer is to decrease the dose of digoxin, but let's go through them one by one. Serial measurements of serum creatinine. It's true that dronedarone increases the level of serum creatinine by 0.2 to 0.3 milligrams, but this is because of decreased tubular excretion of creatinine. It has nothing to do with kidney function as estimated by the glomerular filtration rate. Also, dronedarone, in contrast to amiodarone, does not interact with these drugs. So it doesn't interact with warfarin. As you know, amiodarone increases the level of warfarin because of certain interaction that we will come to very shortly. And at the same time, it interacts with pravastatin and with sulfonylurea, but dronedarone has no interaction with that. What happens here is that dronedarone increases the level of digoxin because digoxin is excreted by a pig glycoprotein, which I will explain soon. And the dronedarone is a strong inhibitor of the pig glycoprotein and therefore elevates the serum level of digoxin. So it should not be used with. Now we move from this to some fundamentals of clinical pharmacology. We have in clinical pharmacology pharmacokinetics, which means what the body is doing to the drug in terms of absorption, distribution, metabolism, excretion. And pharmacodynamics, which means what the drug is doing for the body, the physiologic effects of the drug, variability in clinical response, and a given drug concentration. And then the new science of pharmacogenetics, which talks about the effect of genetic factors on drug response. An example of that, the fast and the slow acetylators of procainamide. The slow acetylators, they are more susceptible to lupus. Also, the variability in the response of warfarin because of cytochrome P269 variants. And also the pharmacogenetics explain the variable in the idiosyncratic response to drugs like group 1 drugs, which are responsible for idiosyncratic effect of prolonging the QT interval and occurrence of torsade de Pointes. Torsade de Pointes and long QT is an idiosyncratic response to group 1, but the toxic effect of group 3. This means that group 1 can produce it without having a high drug level, but group 3, because it's dose related, you have to have a high drug level to get a prolongation of the long QT interval and consequently the occurrence of torsade de Pointes. Drug elimination is also important. The three drugs that are renally eliminated are sotalol, dofetilide, and digoxin. Those sitting in the examination, I bet you that you will get a question about this slide, no matter what you are doing. And hepatic excretion is essentially the route of excretion of lidocaine, propafenone, and amiodarone. Now, this table may be busy, but I will summarize it for you. This shows the excretion and the metabolism of the various antiarrhythmic drugs, whether it's in the liver, the kidney, and the half-life of the drug, and also the active metabolites. If you look here, you will find that drugs like lidocaine 90%, abutolide 90%, amiodarone 90%, dronedarone 90% metabolized in the liver. Whereas if you look into this column, you will find that sotalol and dofetilide is essentially excreted through the kidney. Most of antiarrhythmic drugs, they have lifespan less than 1 day, except amiodarone, which has a half-life of somewhere between 2 and 3 months. So this is the summary of this table. Now, cytochrome P450 system is found in the liver, gastrointestinal mucosa, and the lungs. We will talk after that about the P glycoprotein, which is again found in the liver, gastrointestinal mucosa, and the kidneys. So this is present in the lungs, the other one is present in the kidneys. It's responsible for the oxidative metabolism of the large variety of antiarrhythmic drugs. The main ones are the C3A4, the C2D6, and the C2C9. Now, the genetic polymorphism for the C2D6 results in occurrence of deficiency in certain Caucasian individuals. This is the enzyme which is responsible for the activation and the metabolism of propafenone to change it into the active metabolite, which is 5-hydroxypropafenone. Fortunately, if you have deficiency of this drug, you will get a weak beta blocking effect, because as a result, this is a strong beta blocker. This is a weak beta blocker. This is a strong beta blocker. So you get deficiency here. You keep the beta blocker effect much less. But more importantly, you get a less desirable effect of the drug, because you are preventing the transformation of rhythmonorm or propafenone into the active metabolites, which is 5-hydroxypropafenone. So it's very important to realize this situation in these patients, not by genetic studies, but by observing the patient, its desirable effect and its beta blocking effect. Now, this is a complicated table, but again, it shows three things. It shows the various hepatic enzymes, the C3A4, the C2D6, and the C2C9. And you have here the substrates that are metabolized through these enzymes. And then the inhibitors which inhibit the enzyme, these inhibitors, if they inhibit the enzyme, they result in elevation of the level of these drugs. And the inducers, which are essentially the anti-epileptics, they are inducer of the enzyme, so they decrease the level of the drug. And this applies to these drugs. You need to have a review of this table just before sitting the exam, because this is unfortunately cumbersome and is a topic which is examined frequently. Don't forget that we have the 2C9 is an enzyme that metabolizes warfarin and is inhibited by amiodarone. I just mentioned a while ago, and therefore the combination of amiodarone with warfarin needs to be done cautiously. Otherwise, you get bleeding as a result of increased the level of warfarin. This doesn't apply to dronedarone, because dronedarone does not interact with warfarin. Now, this is the P glycoprotein. As I said, this P glycoprotein is again present in the liver, gastrointestinal mucosa, as well as the kidney, not the lung. And these are the drugs which are metabolized by the P glycoprotein. For cardiology, we are concerned with digoxin and dabigatran. The enzyme was actually discovered for the application of the antineoplastic agents. But these are the two cardiac drugs which are metabolized by the glycoprotein. And these are the inhibitors for the enzyme. Again, if you have inhibition, you get elevation of the drug level. And if you have induction or inducing this enzyme level, you get decrease of the drug effect. So you should be cognizant of this because this is the subject of examination. Now, another important term to be aware of is the phenomenon of use dependence. Use dependence means a greater drug effect at a faster heart rate. The drug is not detached from the channel easily, so if you accelerate the heart rate, it accumulates in the channel and it produces a bigger effect. And this is usually a phenomenon characteristic of type 1C, including the flecainide and the propafenone. It's usually a desirable phenomenon, a positive attribute, because if you have tachycardia, if you have fast arrhythmia, you need the drug to be stuck to the channel to stop it. Except in one condition, which is rate-dependent AV block, because sometimes these drugs produce AV block, so if they get fixed to the channel at a faster heart rate, they are more prone to block AV conduction. And the reverse, which is called the reverse use dependence, means a greater drug effect at a slower heart rate. And here the problem is not in the detachment, it is in the attachment. So if you attach the drug, you need time. If you slow the heart rate, you have ample time, gets attached to the channel and produces a greater effects. It's a phenomenon of class 3 antiarrhythmic drugs, including the amiodarone. And this is the reasons that you get a prolonged QT interval as a result of drug effect with bradycardia. Remember when we talked about the hereditary or familial long QT interval, it is sympathetically driven, and that's why it was treated by beta blocker. But drug-induced long QT interval is dependent on the reverse use dependence, and therefore it depends on slow heart rate, and I will show you this in the coming slides. Now, this is a question number 2, which is relates to the torsade de pointes. You are called to consult a 48-year-old woman being treated for pneumonia in the ICU on hospital day 8 because of non-sustained arrhythmia that is shown above. She has no previous cardiac history, and her admission ECG was normal. She is on the following medications and may be continued in this clinical situation. So which one of them should be continued and which one should be stopped? Now the drugs is haloperidol, erythromycin, sotalol, mexiletine, and methadone. Now the answer here is the only drug which does not produce torsade de pointes among this is mexiletine, which is a 1B drug, has nothing to do with the QRS. Now if you look here, you will find that the patient has a PVC, and as a result of that, you get post-PVC pause. And because of this pause, you get a long QT interval, and this long QT interval results in the occurrence of torsade de pointes. Now, it's very common to be confused between ventricular fibrillation and torsade de pointes. Look in the middle of the tracing. If the amplitude in the middle of the tracing is short compared to the extremes of the tracing, this is torsade de pointes. If it's variable and there is no relation like that, then this is ventricular fibrillation. And the difference is important because torsade de pointes in the large majority of cases is self-terminating, as in this condition. It might degenerate into ventricular fibrillation, but this is not the usual situation, but it's still very dangerous even if it rarely degenerates. Haloperidol is given for psychotic conditions, including the ICU syndrome, but we give it intravenous. And there are claims that intravenous injection, particularly if it's once, twice, or thrice only, doesn't prolong the QT interval and is safe. But if it's used in a tablet form for prolonged interval, it predisposes to the occurrence of prolonged QT interval and consequently torsade de pointes. Erythromycin, sotalol, and methadone, they produce the same thing. Be very careful not to combine two drugs which prolong the QT interval. So the QT interval can result from prolongation of the action potential. It's dose independent for class 1A. It's an idiosyncratic phenomenon. And is dose dependent. It's a toxic phenomenon for class 3 antiarrhythmic drugs, including sotalol, betaline, butylide, and procainamide. Not procainamide itself, but the metabolite N-acetyl procainamide, because it contains the class 3 effect. Now, as I told you, a drug-induced QT prolongation and consequently drug-induced torsade de pointes is usually bradycardia dependent, and it's exacerbated by certain conditions like low potassium, low magnesium, and the use of combination of QT prolonging drugs. You should be familiar with the drugs which produces that, particularly chloroquine in the corona era, as well as erythromycin, haloperidol, and the moxifloxacin. Now, this is an example of drug-induced torsade de pointes. Again, PVC, prolonged pause. You get here type 1 QT prolongation, and then torsade de pointes, which can degenerate into ventricular fibrillation. Remember, the small amplitude compares with the wings here. When it passes into ventricular fibrillation, you don't find that. How you treat? You withdraw the offending agent, you give magnesium. I get asked frequently, why magnesium in this condition? Actually, magnesium is a cofactor for the sodium-potassium ATPase. So it's an important enzyme which is important for balancing sodium and potassium across the cell membrane, and magnesium plays an important role as a cofactor for this enzyme. You correct the hypokalemia, you accelerate the heart rate, because as I told you repeatedly, that drug-induced torsade de pointes is bradycardia dependent, in contrast to hereditary or familial torsade de pointes, which is tachycardia dependent. So the familial form is treated by beta blocker, whereas the torsade de pointes, as a result of drug, is treated by increasing the heart rate, either pharmacologically by isoproterenol or electrically by pacing. Now here there is an important role for lidocaine. Usually amiodarone supersedes lidocaine in treatment of everything except two situations. One of them is this, because if you give amiodarone prolongs the QT interval, but it doesn't produce torsade de pointes except rarely. But the recommendation is that if you go to 550 milliseconds QT interval, you stop amiodarone. If the patient is having left bundle branch block, then you go to 600 because the QRS will be wider, and the QRS is included in the QT interval. Amiodarone and the procainamide, because torsade de pointes should be avoided in this condition. Obviously, you shouldn't use beta blockers because slowing the heart rate by the phenomenon of reverse use dependence will predispose to the occurrence of torsade de pointes. Now, it's important to know the interaction between ICD defibrillation threshold as well as the drugs. Now, you can remember it as follows. If you consider the defibrillation as a depolarization phenomenon, then anything that blocks the phase 0, which is class 1 antiarrhythmic drugs, will elevate the defibrillation threshold, will not allow defibrillation to occur because it's blocking the sodium channel. So actually, all the first class 1 antiarrhythmic drugs plus amiodarone increase the defibrillation threshold. And what decreases the defibrillation threshold is class 3 antiarrhythmic drugs except amiodarone. So class 1 and amiodarone increase the defibrillation threshold. Class 3 except amiodarone decreases the defibrillation threshold. Minimal effect is produced by digoxin, beta blockers, and calcium antagonists. Now, also, the antiarrhythmic drugs have some miscellaneous side effects that everyone should be aware of. One of them is a precipitation of Brugada syndrome. If you look, these are 3 ECGs for the same individual. If you look to the ECG on the left side of the screen here, it's an almost normal ECG. Patient took ajmaline, which is a class 1 antiarrhythmic drug used in Europe, or procainamide, and then this results in the precipitation of type 1 Brugada syndrome, ST elevation with ski sloping inverted T wave in 2 of the 3 right side precordial leads, V1, V2, and V3. Within 10 minutes, the drug was washed out. That's the natural pharmacokinetics of ajmaline, and we turn it back to normal. So using class 1 antiarrhythmic drugs, you should be cautious of not precipitating Brugada syndrome, because this can happen very easily with the patient starting with an almost normal ECG. Now, this is a common phenomenon in patients using 1C drug, propafenone and flecainide. Now, with propafenone and flecainide, although propafenone has a beta blocking effect, its beta blocking effect is weak. And if you give flecainide or propafenone for patients with atrial fibrillation, it organizes the atrial activity and it changes it into atrial flutter. And if the AV conduction is normal, then you get atrial flutter with one-to-one conduction. Remember, these are class 1 drugs, class 1 antiarrhythmic drugs, so they widen the QRS complex. So you end up with wide QRS tachycardia. So it's very easy to be diagnosed as ventricular tachycardia, whereas it's actually atrial flutter with one-to-one conduction, widening of the QRS complex because of the intermingling with the flutter waves, as well as widening of the QRS because of impaired ventricular conduction. If you give beta blocker, which is the recommendation with these drugs, then you slow the rate down and you get the appropriate ECG on. So don't use 1C drugs without prior beta blocking the patient. Otherwise, you get into problem with an accelerated atrial flutter and ventricular tachycardia looking ECG. Now, digoxin is surviving over centuries, so we have to mention something about digoxin. It's not used very frequently at the present time. The major indication is actually patients with congestive heart failure and atrial fibrillation to slow the ventricular rate, particularly as a second agent in addition to beta blockers and or calcium antagonists. It's largely obsolete and for other reasons. But an important point, an important second point, the first is that don't use dronedarone in patients with permanent atrial fibrillation. Also, don't use digoxin in patients with paroxysmal atrial fibrillation. So paroxysmal, no digoxin. Permanent, no dronedarone. Why don't use it in paroxysmal atrial fibrillation? Because the sudden occurrence of atrial fibrillation in this condition is usually associated with intense sympathetic stimulation, and this will block the vagotonic effect of digoxin and nullifies its action. So it's contraindicated in patients with paroxysmal atrial fibrillation. Mechanism known to everybody, it blocks the sodium-potassium ATPase. This is the enzyme which has magnesium as a cofactor of it, and therefore it increases the amount of sodium inside the cells, which gets exchanged with calcium, so it increases amount of calcium. Actually, calcium is responsible for its antiarrhythmic effect as well as pro-arrhythmic effect. So the different pro-arrhythmia here, which I will show you a wide variety of them now, is actually due to calcium overload. Remember, it's excreted through the P-glycoprotein, which is present in the gastrointestinal mucosa, liver, as well as the kidney. It has a half-life of 1.5 to 3 days. It's excreted renally, so you have to be cautious in patients with renal failure. Everybody knows that. But you have to know that these 3 drugs, amiodarone, dronedarone, and verapamil, they antagonize the P-glycoprotein and consequently they increase the level of digoxin. Now, these are various ECG which shows the common pro-arrhythmias resulting from digoxin, atrial fibrillation with the 3rd degree AV block, atrial tachycardia with 2nd and the 3rd degree AV block, bidirectional ventricular tachycardia. You cannot detect it easily if you don't have a 12 electrocardiogram. Remember, the only differential diagnosis for this is CPVT, polymorphic catecholaminergic ventricular tachycardia. So if you get bidirectional ventricular tachycardia, you have to look to the stem of the question and see the circumstantial evidence. Is it digitalis toxicity or is it CPVT? Also, it can produce a variety of ventricular arrhythmias, including ventricular fibrillation. Now, the proarrhythmia induced by digoxin, it can be enhanced by the occurrence of alteration in calcium level, including the hypokalemia and the hyperkalemia. Hyperkalemia with proarrhythmia is an indication for DG-bind. I will come to that soon. It's also predisposed to by occurrence of heart failure, cardiomyopathy, renal dysfunction, elderly, and the use of drugs which prevent the excretion of verapamil by antagonizing the P-glycoprotein. Treatment, correcting potassium and magnesium. Of course, if you have potassium elevated, all what you do is to have to go to the DG-bind. Xylocaine is the other condition in which lidocaine supersedes amiodarone. We don't use amiodarone here because amiodarone will block the P-glycoprotein, elevates the digitalis level. So lidocaine is important in this condition. It supersedes the use of amiodarone, and you use antidigoxin antibody fragments, which is not available in Egypt here, particularly if the patient is having refractory VT and VF. Remember, we don't shock these patients easily because shock will produce arrhythmia in this condition, and particularly if the digitalis toxicity is associated not with hypokalemia but with hyperkalemia. Everybody knows the DASH trial, which is the only randomized trial done almost 20 years ago, and it was a neutral trial here. But several years after the publication of the DASH trial, we had another smaller trial, which showed us an important thing. The effect of digitalis is equivalent in the small doses, but the toxicity is less whenever you have a digitalis level somewhere between 0.5 and 0.8 nanogram per milliliter. So we usually opt for a smaller blood level. This doesn't mean that we regulate our digitalis dosage by frequent carrying out of digitalis level. We can do it once or twice, and whenever we change the dose of digoxin, we use digitalis level only to monitor toxicity and not to indicate the dose. We usually use small dose to achieve something, the blood level of equal or less than 0.8 nanogram, and certainly less than 1 nanogram. Now, the third question is a 26-year-old woman with a history of bronchospastic asthma requiring steroid treatment presents to the emergency department with sustained palpitation, dyspnea, and chest tightness. Her blood pressure is 110/75. She looks uncomfortable and is tachycardic, but examination is otherwise unremarkable. This is her ECG. It's a supraventricular tachycardia, and the carotid sinus massage was done, had no effect. So what is the most appropriate next treatment? Is it intravenous adenosine, magnesium, synchronized cardioversion, oral digoxin, or verapamil? Now, this is an asthmatic individual with resistant asthma resisting steroids. You cannot use adenosine in these patients. This is the message that I want to tell you about it today. So verapamil, as I said, is equivalent to adenosine, but the difference is adenosine should be given as a push, rapid push as a bolus, and the verapamil should be given by slow infusion. So this leads us to discuss adenosine. Now, the adenosine receptor is present all over the body, but in the heart there is a specific adenosine receptor, which is adenosine 1 receptor, A1 receptor. Now, A1 receptor, if it gets activated by adenosine, it opens a specific potassium channel among the 14 potassium channels that I showed you in the first slide of this lecture. And this potassium current is called adenosine. And what this potassium channel does is that it allows potassium to come in rapidly, and this leads to hyperrepolarization of the cell. And if you have hyperrepolarization of the cell, it cannot conduct. At the same time, it blocks the calcium channel, so again, it cannot conduct. And the hyperpolarization plus the calcium blocking effect, this is the reason why it blocks the AV node and abolishes AV nodal re-entry tachycardia or wherever or any arrhythmia that passes through the AV node, including AV re-entry tachycardia. So it's the hyperpolarization of the cell as a result of opening the potassium channel, as well as the secondary effect of calcium channel blocking effect. These are responsible for the mechanism of action by adenosine, which is given as a 6 milligram rapid push. And if not successful, we double the dose. We might repeat the double the dose. If it's not available, and it is not available usually in Egypt, replace it by verapamil. It's equally effective. Now, the clinical effects of adenosine, it slows the AV effect, AV block, shortens the atrial refractory period. And if you remember that anything which shortens the atrial refractory period for a reason that I explained before will result in atrial fibrillation. So this is the reason why it can produce atrial fibrillation. It's also used with the ablation of atrial fibrillation after making the ablation line in order to make sure that there is no conduction from the pulmonary veins to the rest of the atria. So if you give the patient adenosine after you ablate the sinus, the pulmonary veins, and there is no atrial fibrillation precipitated within half an hour after the resuscitation procedure, you are confident that this procedure is successful. In addition, verapamil is equally effective in terminating the sinus supraventricular tachycardia. The side effects of adenosine include flushing, headache, and chest pain. This chest pain is not angina, it's because of the irritation of the nociceptive fibers in the AV node and the adjacent area of the right atrium. It can produce asystole because of the hyperpolarizing and calcium antagonizing effect. It can precipitate atrial fibrillation because it shortens the atrial refractory period and it produces bronchospasm. The A1 receptor is occupied by caffeine and theophylline, so patients who are drinking a lot of coffee or taking theophylline for asthma, they cannot respond to it. And in contrast, the hyperresponders, including heart transplant individuals and the bipyridamole, which antagonizes the phosphodiesterase type 3. Now we will go now for the last part of this lecture through certain bullet points, which are the important points that you need to remember about antiarrhythmic drugs. So starting from class 1A drug, including quinidine, we are rarely using quinidine nowadays because of its toxicity, but it has a potential niche in treatment of Brugada syndrome. Remember, Brugada syndrome is hyperactivity of the ITO, transient out current responsible for phase 1 repolarization. So it's hyperactive in these conditions. If you block it, and the quinidine has this effect, a niche effect in blocking the ITO, which is transient outward current, and therefore this is the main use of quinidine at the present time. Procainamide, again, is not present in the oral form. It's available only in the intravenous form, and it's not available in Egypt since a long time. Remember that there are slow acetylators and rapid acetylators, and acetylation will result in the production of NAPA, or N-acetyl procainamide, which has a class 3 effect, changes it from class 1A into class 3 effect, and consequently it blocks the potassium repolarization, prolongs the QT interval, and precipitates torsade de pointes. It's also used in treatment of monomorphic ventricular tachycardia and atrial fibrillation with WBW. It can be used to unleash Brugada syndrome, as I showed you, Ajmaline in Europe, procainamide in the United States. Disopyramide also is not available frequently. It has an important anticholinergic effect. Shouldn't be given in patients with glaucoma or senile hypertrophy of the prostate. It has a strong negative inotropic effect. That's why it's frequently used in hypertrophic cardiomyopathy. And it has a vagolytic effect, so it's used in patients with vagally mediated atrial fibrillation, like postprandial or nocturnal atrial fibrillation. Class B drug, we have lidocaine. It's inactivated by the hepatic microsomes, so the dose should be reduced in patients with congestive heart failure, myocardial infarction. It should not be given prophylactically in myocardial infarction after 20 or 30 years of making this mistake, because it leads to sinus arrest. It has serious neurologic side effects, and it has a niche value in the treatment of torsade de pointes, as I mentioned to you, digitalis toxicity and torsade de pointes. It's superior to amiodarone in both of these conditions. Also, mixilitine is not available, but remember, mixilitine is used now in treatment of long QT3. Long QT3 is a gain of function of the sodium channel. Remember, gain of function of the sodium channel. Brugada is loss of function of the sodium channel. So this blocks the sodium channel, and therefore it's used in patients with long QT syndrome. Class 1C is the strongest group of antiarrhythmic drugs among class 1 drugs, including flecainide. This flecainide has been used in the CAST trial, so it doubled the mortality. So this drug should not be used in patients after myocardial infarction. It has the phenomena or the characteristic of use dependence. It should be given with beta blocker, otherwise it will get organization of atrial fibrillation into atrial flutter with one-to-one conduction, and the ventricular tachycardia looking ECG will result. Remember that flecainide is used in a special condition, which is the CPVT. CPVT is a leaky ryanodine receptor, and flecainide, apart from its effect as 1C drug, it's a ryanodine receptor stabilizer. So it stabilizes the liberation of calcium from the ryanodine receptor and stops the CPVT. Propafenone is available in Egypt. Again, it's the results of the CAST trial applies to it, and it's similar to flecainide. It should be used with beta blockers, although it has some intrinsic beta blocking effect. There is a deficiency of the enzyme which changes, which is 2C, 2D6, C2D6, which is responsible for the activation of propafenone into 5-hydroxyl propafenone, which has a little beta blocking effect. Now, beta blockers, they are important in treatment of ischemic heart disease and congestive heart failure, particularly if it has an ischemic underlying etiology. It's very important in treatment of ventricular tachycardia storm, which is by definition 3 attacks of ventricular tachycardia within 24 hours, because this storm is usually sympathetically driven, and if you block the sympathetic nervous system, you can overcome it. At the same time, it's used in the treatment of congenital or hereditary long QT interval and anticonvulsant. Obviously, it cannot be used and is contraindicated in the treatment of drug-induced long QT interval because it's bradycardia dependent. Class 3 drugs, we have sotalol. It's renally excreted. It decreases the defibrillation threshold. Its major use is in the reversion to sinus rhythm of patients with atrial fibrillation, but it's also used to block the occurrence of ventricular tachycardia in patients who are having an ICD. Dofetilide is renally excreted. It should be initiated in the hospital by a protocol of 3 days. The patient remains in the hospital. It's labeled for persistent atrial fibrillation, and it lowers the defibrillation threshold. As I mentioned, class 3 except amiodarone diminishes the defibrillation threshold. We don't have ibutylide, but it's an important drug. It's used for the termination of atrial fibrillation and atrial flutter, more successful in the treatment of atrial flutter than in atrial fibrillation. The dose is simple. There is no infusion, but it's given 1 milligram over 10 minutes and repeated once again. It blocks the IKR. All the drugs block the IKR, not the IKS, except the Macaland, which blocks the IKUR. And it produces torsades similar to the dofetilide and sotalol in 1 to 5%. It converts atrial flutter and the atrial fibrillation to sinus rhythm in 30 to 60%, better for atrial flutter than in atrial fibrillation. And it can be used for atrial flutter that's refractory to electrical cardioversion, to give ibutylide, to repeat the cardioversion, get more success. Amiodarone, that, as I told you, acts by the 4 mechanisms, blocking the sodium channel, potassium channel, and beta blocker, calcium antagonist. It improves the survival to hospital admissions in patients with out of hospital cardiac arrest. It has no effect on mortality, as revealed by the Scott-Hefty trial. It raises the defibrillation threshold by an average of 1.7%, but sometimes it's up to 17%. It has a large volume of distribution of 50 liters, and therefore you have to be eluding the dose of 8 to 10 grams over 2 to 3 weeks, and it has numerous side effects. And the numerous side effects every system in the body except the kidney. The kidney is not involved, and the lungs are involved, the thyroid gland is involved. It's an opposite because it's a rare complication, but we know patients are having severe ataxia that have been treated by a variety of ways, and they take the regular dose of amiodarone and the response.
برضه صوت حضرتك بيقطع.
not common but
سامعني؟
drug interaction with amiodarone not existing with amiodarone, including inhibition of warfarin, digoxin, وراك. كده الصوت كويس؟ محمد.
ايوه حضرتك، الصوت ابتدى يقطع من اول السلايد دي، لو حضرتك ابتديت تشرح السايد افكتس اوف اميودارون.
هحاول تاني في خط الانترنت تاني. كده كويس؟
تمام، اتفضل يا فندم.
تمام. So as I said, amiodarone has a toxic effect on all organs of the body except the kidney. I want to call your attention to rare but very serious side effects, including ataxia as well as sudden loss of vision because of optic neuritis and retinopathy. It has a drug interaction with these drugs and elevates them, so you have to be cautious with its use. Now, as you know, we have to do liver function tests at baseline and every 6 months. Same applies to thyroid function tests. You have to do a chest X-ray yearly, ophthalmoscopic examination at baseline and when indicated, pulmonary function test at baseline, and then when indicated, high-resolution CT at baseline, and when indicated, the CT and echocardiogram if you have any evidence of toxicity. Slides. Dronedarone is similar in electrophysiologic action like amiodarone, no iodine molecule, and therefore it's approved for treatment of atrial fibrillation and atrial flutter only. There is no effect at all on ventricular tachycardia or ventricular fibrillation. In the Athena trial, it reduced the cardiovascular hospitalization. The important 2 points: avoid in systolic heart failure as revealed by the Andromeda results, and in permanent atrial fibrillation by the Palace trial. Calcium channels, they have greatest effect on the AV node and the sinus node. They can be used to control the rate in patients with atrial fibrillation. They are ideal for chronic treatment and suppression of supraventricular tachycardia. IV verapamil is as effective as adenosine in AV nodal reentry tachycardia. You have to give it slowly to avoid side effects of hypotension. It may raise the digoxin level and has a synergistic bradycardic effect with beta blocker because of, as I showed you in the slide of action of beta blocker, the downstream signaling pathway involves the calcium entry into the cell applicable to both. So actually, we passed quickly through von William classification, major clinical uses in the acute setting of cardioversion and cardiac arrest, various drugs that are used in treatment of atrial fibrillation, and the various drug use of treating ventricular tachycardia and avoiding ICD shocks. And it's important to be on the lookout for major side effects, interactions, and proarrhythmia, and pay particular attention for the drugs that are commonly used like amiodarone, flecainide, sotalol, dronedarone, profitaline, and digoxin. Thank you very much, and I'm ready to get your questions.
شكرا لحضرتك يا دكتور محمد. الأسئلة جت، في حد بيسأل عن اليوز ديبندنس الليدوكين.
اليوز ديبندنس الليدوكين ملوش يوز ديبندنس. اليوز ديبندنس 1A والريفرس يوز ديبندنس كلاس 3.
اوكي. سؤال تاني بيسأل عن patients with CYP2D6 polymorphism. هل بنستخدم بيتا بلوكرز مع البروبافينون ولا لا؟
البروبافينون لازم consistently ما يستخدمش لوحده. Otherwise you will get organization of atrial fibrillation into atrial flutter, وبالتالي يحصل one-to-one conduction of the AV node is healthy. هو كمان بيimpair الانتراventricular conduction, so the QRS complex will be widened, هتقراها فنتريكولار تاكيكارديا وتديله لايدوكين بالظبط عكس اللايدوكين بيفاسيليتيت البي كوندكشن، وبالتالي العيانين اللي هم تحصل على اكسلريشن اوف ذا ريت للاريزميا دي rather than stopping it. كل الحكايه انك انت محتاج تدي العيان بيتا بلوكر بيفور بروبافينون انه يتاخد. في البيل ان ذا بوكيت we give combination of propafenone and beta blocker, not propafenone. Although propafenone by itself has a beta blocking effect, but it's a weak beta blocking effect.
في سؤال بيسأل does the side effects of amiodarone especially on the thyroid gland limit its usage in AF ولا لا؟
لا, it doesn't limit its use in AF if you think that you are failing انك انت maintain sinus rhythm by other drugs and you are forced انك انت والعيان رافض ablation, then you give amiodarone. If the patient gets hypothyroidism more than hyperthyroidism, but you treat the hypothyroidism and it's continuous amiodarone. Usually with atrial fibrillation we have an exit وهو ablation. لكن the problem comes with ventricular arrhythmia. With ventricular arrhythmia الابليشن is more difficult. يعني افرض واحد عنده very frequent PVCs 20,000 PVC ب 24 hours in the cardiomyopathy and he's refusing the ablation. حتى الابليشن ممكن ما يبقاش successful لانك you cannot localize easily the ectopic focus. او there is more than one ectopic focus 5 6 اللي هم عاملين ال 20,000. Then you put the patient on amiodarone. Now if the patient develops hypothyroidism you treat the hypothyroidism. If the patient develops hyperthyroidism you treat the hyperthyroidism up to thyroidectomy. If you feel that amiodarone is mandatory. عادة في اكزيت. ايه هو الاكزيت؟ الابليشن. الابليشن بالتاكيد الاكزيت مش درونيدارون.
اوكي. في سؤال تاني بيسأل عن الميكانيزم اوف هايبوثايروديزم اند هايبرثايروديزم caused by amiodarone.
الميكانيزم اوف هايبوثايروديزم ايزلي ان الاميودارون فيه ايودين مولكيول so it's taken by the thyroid gland. The thyroid gland is very avid للايودين molecule. It blocks انك انت بالطريقه دي هي تاخد التيروزين اللي بيتحول الى مونو ايودو تيروزين الى داي ايودو ثيرونين الى تراي ايودو ثيرونين. So it blocks the formation of thyroid hormone. This is called the Wolff-Chaikoff effect. Give iodine you block the formation of thyroid. عشان كده كنا بندي ايودين في وقت من الاوقات عشان نحضر العمليين لغايه الان العيانين اللي عندهم thyrotoxicosis for surgery. Now thyrotoxicosis بقى في two types. تايب منه increase the area deprived of iodine او عندهم goiter. You take more iodine, form more thyroid hormone, you liberate more thyroid hormone, you get thyrotoxicosis. النوع الثاني is an idiosyncratic.
دكتور محمد هو صوت حضرتك قطع. دكتور محمد.
iodine deprived areas او عندهم goiter. النوع الثاني عباره عن idiosyncratic reaction في destruction للثيرويد جلاند. النوع الثاني ده is treated essentially by corticosteroids اساسا عشان to prevent the inflammatory reaction. So we give amiodarone what is essential and we treat the thyroid problem. ده كان الكلاسيك لكن دلوقتي بقى عندنا exit في الحاله دي هي وهو الابليشن. So if ablation is refused or it is not available you do whatever I said. If it is available then it's better انك انت you waste your time or you struggle with the thyroid gland you might or might not achieve a success.
هل في determinants للعيان هل هيديفلوب هايبوثايروديزم او هايبرثايروديزم؟
هل في ايه؟
في حاجه ديترماين العيان ده هيديفلوب هايبوثايروديزم او هايبر ثايروديزم؟
فاميلي هيستوري. العيانين اللي عندهم ثيرويد فاميلي، لكن هو عند في عائلات تلاقي في كذا واحد عنده ثايرويدسكوزس او هايبوثايروديزم. العيانين اللي هم عايشين في الحتت الجبليه وبالتالي ما عندهمش ايودين، اللي في الارياز اللي فيها السولت نوت فورتيفايد باي ايودين، كل دول عيانين بروديوس susceptible to thyroid disease. If you are susceptible to thyroid disease, you are susceptible to amiodarone-induced thyroid disease. طبعا وي تراي ان احنا نخلينا بالسمولست دوز اوف اميودارون، يعني عاده الدوز ما بتزودش عن 200 مللي جرام، لكن ان سيرتن تمبريتشر اريزميا يو ار فورسد انك تدي 400 مللي جرام. سو الدوز الكبيره دي هي اللي بتأدي كده. في 1 بوينت انا ما اعرفش ليه ما بتسالوش عنها. وات اباوت العيانين اللي هم بياخدوا اميودارون انترافينسلي لما بيخش الانتنسيف كير بمايوكاردال انفاركشن وعنده اتريال فايبريليشن او عنده فنتريكولار اريزميا and then you wanted to change him into oral. هل تلود him again ولا تديه بس القلب؟ This is not clear in the literature, not clear in the guidelines. There is no trial tested الكلام ده. لكن what I'm doing is that if the patient takes intravenous amiodarone, I calculate the dose واطرحها من 8 ل 10 جرام واديله الباقي oral over the subsequent 2 to 3 weeks. This is a very common practical point. ده اللي انا بعمله. I might be right, I might be wrong. لكن لو في حد قاري حاجه في الموضوع ده يقول لنا ايه رايه في الموضوع ده. This is not you can't get the answer of this question, although this question is very commonly encountered in practice.
سؤال تاني بيسأل عن treatment of VVCs in structurally normal heart.
Structurally normal heart VVCs احنا اتكلمنا فيها المره اللي فاتت او المره بتاعت الفريكوال تكرر. We start with beta blocker. Always we start with beta blocker. Second, the choice will be 1C drug. Rarely we resort to class 3 drugs. هم دول اللي احنا بنشتغل بيهم. Beta blocker, 1C drug, 1A, 1B, they are highly toxic drugs. أو بالنسبة ل 1B they are less efficacious وليهم suppression للconduction والساينس نود. عشان كده بطلنا اللايدوكين except في التو situations اللي أنا اتكلمت عنها. So we give beta blockers نمرة واحد على أساس إن ممكن تكون sympathetically driven. If not, then we block the sodium channel by 1C. If not, we block the potassium channel by class 3. So that's it. If not, then we ablate. الابليشن ممكن تعمله as a first step إذا كنت قادر تلوكلايز الأورجن بتاع البي بي سيز أو البي بي سيز اللي هي irritating. irritating يعني إيه؟ يعني إما disturbing العيان في palpitation يا إما عاملة بي بي سي أو arrhythmia induced tachycardia induced cardiomyopathy.
في سؤال بيسأل is liver disease an absolute contraindication for the use of amiodarone?
No. Liver disease is not absolute contraindication to amiodarone, but we have to be careful بإن إحنا ندي smaller dose. We have to be careful إن إحنا we watch السيرم bilirubin, الالكالاين فوسفاتيز and ALT and AST. إذا الالكالاين فوسفاتيز عالي، إذا السيرم bilirubin عالي، إذا التانيين عدوا 3 أضعاف وستوب.
اوكي، ده كان اخر سؤال يا دكتور محمد.
طيب
شكرا لحضرتك.
شكرا يا سيدي الناس، يا اهلا وسهلا.